Thank you very much, Karen. I'd like to thank the All Ireland Institute and the Palliative Care Research Network for inviting me here, and particularly to Mary and Karen for making me so welcome here. I'm always delighted to come back to Ireland, and Dublin particularly. As Charles pointed out, Ireland is the spiritual, if not the historical, home of palliative care, with the work done by Mary Aikenhead and, of course, the nuns in Cork as well. So it's always nice to come back and root myself in the origins of where it all began. So I'm going to talk about the NICE guideline, which was just published a few weeks ago, and specifically focusing on the recommendations regarding out-of-hours care. As it says there that I am now an emeritus professor from the University of Sheffield, but since my retirement I do work for NIHR, that's the National Institute of Health Research, National Cancer Research Institute, because my background is oncology and respiratory medicine, and for many years I've been working with NICE. So here's my declaration and disclaimer. In the past 10 years I have worked with NICE on various guidelines, technology appraisals, etc., quality standards. I've worked with the Royal College of Physicians on their National Care of the Dying in Hospitals audit. I've worked with the National Institute of Health Research, Clinical Research Network, particularly focusing on supportive care studies, and the National Cancer Research Institute as well. Yes, I get them mixed up as well sometimes. But particularly focusing now on, we have a new research group, by the way. It used to be called Supportive and Palliative Care. It's now called Living With and Beyond Cancer. If you want to know more, we can ask me about it later. Important line at the bottom is, although I'm drawing on all that work in this presentation, I don't speak on behalf of any of those organizations. I'm not an official from NICE. So what has NICE produced recently, say in the last 10 years, for people who are approaching or actually at the end of life? Well, they produced improving outcomes guidance. That was the old terminology many years ago. Guidelines and quality standards, and I'm going to be talking about a bit of each of those. Now, NICE actually started this process a long time ago. In 2004, I don't know how many people can remember the Improving Supportive and Palliative Care Guidance for Adults with Cancer. This is in the days when they were called Improving Outcomes Guidance, and there was a lot of it in the cancer area, and this is why this one was developed in the cancer area, but for supportive and palliative care. And it helped to put supportive and palliative care on the map in terms of healthcare delivery. These are the topic areas within that NICE Improving Outcomes Guidance in 2004. Lots of different areas which kind of mapped out the territory. And for the last decade, we've been kind of working to that agenda. You see the very last one I've highlighted there at the bottom, number 13, was research in supportive and palliative care. And what I've been doing the last, well, since then, but even before then, is actually trying to deliver that research. It actually, although it was about supportive and palliative care, it did say a little bit about out-of-hours care. And I've highlighted a few elements in the 2004 guidance. It talked about, for instance, in general palliative care, coordination of care teams in and out of hours and across boundaries of care. Teams should develop mechanisms to ensure the transfer of relevant clinical information, including out of hours using paper or electronic handover forms, which was just a wish list back then. One of the statements was that relevant information is passed to those providing care out of hours. And then finally, again, research is needed to determine cost-effective ways of providing general palliative care to patients and families out of hours. So that's kind of set the agenda, even way back in 2004. So what was the impact of that guidance? Well, it kick-started the modern supportive care agenda, particularly in cancer, less so in other areas, particularly in hospital. It drove multidisciplinary team working for end-of-life care in cancer. It was a kind of a wave that enabled that to happen, particularly in the acute sector. It established holistic needs assessment. That was the new phrase then, back in 2004. Very much in cancer, well established now, less so outside of cancer. And it was supposed to be about investment in research for end-of-life care. What did it achieve? I won't lie to you, not a lot. Actually, it didn't deliver a lot in terms of the research. That came a bit later. Now, let's just look at all the NICE guidelines that have come out which are relevant to palliative and end-of-life care. So there was the Improving Supportive and Palliative Care for Adults with Cancer. That's a service delivery guideline. NICE produces clinical guidelines, which is what most people think about with drugs, cancer drugs, but also service guidelines. So that was the service guideline. Then in 2015, we published the Care of Dying Adults in the Last Days of Life. That was a clinical guideline. That's actually what clinicians at the bedside should be doing or not doing for people who are in the last few days of life. And now, very recently, last month, we published the end-of-life care guideline for end-of-life care in adults, focusing on service delivery. So that's a service delivery guideline. So these are meant to work alongside each other. I've put it in dimmed out there, end-of-life care for infants, children, and young people. Very important, but I'm not going to talk about that. But NICE also produces quality standards. I don't know how much they recognise or apply here in Ireland, but they're important for the delivery of healthcare across England and Wales and Scotland and Northern Ireland. There's the Care of Dying Adults in the Last Days of Life, that's QS 144, and that's matching the NICE guideline NG31, which is about care in the last days of life, is taking a few key statements out of that whole big guideline and make them into quality standards. And then there's also been an older one, end-of-life care for adults, and that's about service delivery. That predated the guideline I'm just going to tell you about, the one about service delivery, and it probably will be updated now because we produced the last guideline. But it was for people who are likely to die in the in the next 12 months. Clinical guideline, that's the quality standard up there, and then service delivery guideline, and that's the quality standard there, QS 13. So NG31 is kind of where we really got going with this, published in 2015. It started off after the whole story about the Liverpool care pathway, and Baroness Neuberger's commission basically said we need to do away with the LCP but have individualized care plans. Care of dying should be based on evidence. She was horrified what little evidence there was for end-of-life care, and particularly also in the hospice world as well as in hospital. So NHS England commissioned NICE to produce a clinical guideline to address the gap after the LCP. So what did the NG30, I'm not going to talk in detail about NG31, but what did it say about out-of-hours care, the clinical aspect in the last days of life? For instance, it said to identify a named lead healthcare professional who was responsible for encouraging shared decision-making. The named healthcare professional should give information about how they can be contacted and contact details for relevant out-of-hours services to the dying person and those important to them in any setting, hospital, community, hospices, care homes, whatever. And then there was a research recommendation for agitation and delirium. Most people who are dying are not under the direct care of such specialists, although they may be called in for advice out of hours. And this is addressing the need that actually there are gaps, and we heard this already before from the Voices work, that there are gaps in how we deliver care, pain control, and, for instance, agitation and delirium out of hours. And then there are several other references to the delivery of care at the bedside, wherever the patient is in the last days of life, with patients being on drugs or on hydration, where they need to be reviewed every 4 to every 24 hours. So that will necessarily involve out-of-hours care as well. So what's been the impact of NG31 4 years on? There's been much better move towards better communication, individualized care planning, shared decision-making. Across the country, I go across England, and there have been big changes since the Liverpool care pathway. Some of them a little bit cosmetic, but people are actually moving forward. Very great attention to drug prescribing, which is a big focus of the NG31, moving towards an individualized rather than the tick box approach. Been significant recognition for those who need and actually then get artificial clinically assisted hydration. And it has stimulated research, much of it funded by NIHR, Marie Curie, but interestingly, as far as I could see, none on out-of-hours care. Sabine is shaking her head at me. Yes, there is out-of-hours care. Thanks for telling me. But none that I could find when I was making this slide. So, who was on the Guideline Committee for producing the new guidance, NG 142? Well, that's a photograph taken of most of the Guideline Committee right towards the end of the process. It took us nearly 3 years to develop this guideline. So who was actually on it? we had a chair who was a non-specialist. NICE now insists on having a chair for a guideline who is not a specialist in the topic of the guideline. That means that they're not biased, they're more objective. And we had Mark Thomas, who's a renal physician. I was the specialist advisor because of my background in supportive and palliative care, and we had members who were patient and carer representatives, including people representing young carers. We were very concerned about people representing carers who were either in their teens or young adults. Nurses, doctors, allied health professionals, social workers, also had commissioners, and then of course we had the NICE guidance team, the management team, the technical people, the information scientists, economists, and also the editorial team. So really altogether probably would have been about 3 times the number that you saw in that photo. This was a multi-professional team, and it covered all the sectors. It covered community, acute, hospice, and social care as well. So the background, the rationale for delivering NG 142, this service delivery guideline, is that it covers the organising and delivery of end-of-life care services in the final weeks, months of life, and we recognise that in some conditions, some long-term conditions, it may be many years actually, so we didn't put a timeline on it. The earlier guideline, the quality standard, talked about the last 12 months of life. It's no point talking about a specific number, so it's months, maybe years. And it covers all care settings, particularly also looking not for care for patients, but care for carers as well, especially the younger ones. It describes the provision of end-of-life care services for adults with any conditions or diseases. We were quite agnostic to the condition. Of course, there's been a lot of work in cancer, but increasingly in non-cancer conditions as well. And it advises on service models in acute settings, community settings, across wherever NHS care is delivered, which is including a lot of hospices, also prisons and other kind of settings too. And it is meant to work alongside NG 31, which is the care of dying in the last days of life. So the two go together. One's clinical, the last days of life, one's service delivery, how you get people ready for those last days of life. So these are the topic areas in NG 142, all sorts of things, identifying adults who may be approaching the end of life, assessing holistic needs, providing information, supporting carers, reviewing the current treatment. We're very strong on advising particularly hospital specialist teams to know when somebody is approaching the end of life, how to back off, how to change their approach so that they're not, holding on to patients, bringing them back for unnecessary hospital appointments, that kind of thing. Advanced care planning is very important. Reviewing the needs as time goes on, and time may be quite long for some of these patients who are in end-of-life care for months and years. Communicating and sharing information between services, very important aspect of that, how you communicate, electronic means as well as paper. Providing multi-practitioner care, providing end-of-life care coordination, transfer between care settings. We know that many people need or want to be transferred back home towards the end of life. Then finally, the last one was providing end-of-life, out-of-hours care. So this is the recommendation on providing out-of-hours care. It says that adults approaching the end of their life, their carers, and other people important to them should have access to a healthcare professional who's available 24 hours a day, 7 days a week, not obviously the same one, but a team, who can assess the person's records and advanced care plan. Very importantly, people coming in on a rota won't necessarily know the patient, but they need to know within minutes about that patient's background using an electronic register of some sort, and make informed decisions about changes to care. Also, they should have access to an out-of-hours end-of-life care advice line, usually on a telephone, and an out-of-hours pharmacy service, which has access to medicines and also devices like pumps, etc., for people approaching the end of life. Now, I did a piece of work with the Royal College of Physicians a few years ago. We published this in 2016, and this was a national audit of nearly 9,700 patients across England who looked at their care in their last hospital admission. So this was hospital care for people who were dying. And this particular is focusing on out-of-hours care in the hospital when people were dying. The top line is that only 11% of hospital trusts actually offered a face-to-face 24/7 service. only 11%. There's been a more recent survey by Nasal Group. The number's gone up a little bit, but not significantly. 37% of sites had face-to-face access Monday to Sunday, 9 to 5, but what happens out of hours, 5 till the next morning. So it was very, very poor. If you looked at telephone advice, again, for people who are dying in hospital, yes, it was much better. And so even in a large hospital, you could always get hold of somebody, and then maybe somebody, 11% of services, had a person who would come to the bedside. Interestingly, if a hospital trust had a specialist palliative care bedded unit within it, it was only a small number, it actually doubled the number, so 22% provided a 24/7. So it's still not very much, still a small minority, but actually it was better if you had a specialist palliative care service in the hospital. So 26 trusts, this is back in 2016, I don't know what the number is now, 26 hospital trusts in England did not provide any level of provision of face-to-face specialist palliative care, including doctors, at any time or day or night. I don't know how that's sustainable. I don't know how that's justifiable in the country that we're told has the highest rating in the world. So, I'm a bit sceptical about that. So the Royal College of Physicians' recommendation is that all trusts should have access to specialist palliative care. Now that's very much trust-based, but I just wanted to slip that in to show a piece of very focused work that we did a few years ago. I love this one. The chief executive thinks we have to provide better cover at weekends. He'll be making an announcement when he gets in on Monday. We all need to pull our weight. So this was the review question for NG 142. What are the best out-of-hours services, models, and policies to support people in their last year of life to stay in their preferred place of care? So it was a kind of very focused question because, I was very interested to hear from Bridget about the piece of work you've done, which I presume is a more broader focus. We focused right down because we wanted to know what's going to make a difference to people. So basically we said to support people in their last year of life to stay in the preferred place of care. Not necessarily of death, because it might change towards the very end. Now, when we set up a guideline, the committee is very important in a key action, and that is setting what are the critical outcomes and what are the important outcomes that the technical team and the literature team have to then find the evidence for. So the committee decided 2 levels of outcomes, how to measure the impact of an out-of-hours service. The critical outcomes were quality of life and the preferred place of care and death, and whether people achieve that or not. So that what we thought was critical. We have to absolutely have that information. Other important, nice to have information would be the length of stay in hospital, length of survival, number of hospitalizations, number of visits to accident and emergency, lots of things there. You can read about the number of inappropriate attempts at cardiopulmonary resuscitation, for instance. Very importantly, staff satisfaction, patient or carer reported outcomes, and carer health. So with that kind of research question and those levels of outcomes, we then asked the literature team, the information scientists, and the technical team to work on that. We work on using a standard PICO system, so that was the PICO. When you go on the website, you'll see the very specific criteria that we used for the population, the intervention, the comparators, the outcomes, and then finally, we looked at all study designs. We looked at systematic reviews, RCTs, randomized controlled trials, non-randomized comparative studies, including before and after kind of studies. So, I never thought I'd say this, but NICE seems to be more generous than the piece of work you did. We actually identified 4 studies. So I was very interested to see that you've identified 0. I'd love to be able to swap notes with you afterwards, Bridget. We included 4 studies in the final analysis data set. There were 2 from the UK, 1 from Spain, and 1 from Canada. All of these were observational, either non-randomized or pseudo-randomized, comparative kind of studies. Some of them were before and after, so they were not actually, they wouldn't have made the cut for many NICE guidelines, I'm afraid. All the evidence was rated as low quality or very low quality, and this is using a very objective system that NICE uses called GRADE. It's used elsewhere, Cochrane uses it, for instance. And these were mostly downgraded to those low levels of quality because of risk of bias, imprecision in the actual data, or indirectness. So, for instance, they were not all necessarily about people in the last year of life, but they were good enough because they're people with long-term conditions. none of the studies provided any useful health economic data. And so the economic model, which I'll show you, was based on what the standardized UK health research costs and the opinions of the committee. So we worked together with the health economists. We didn't have any data to go on. So just very quickly, study one was a UK study, small study. It was about a rapid response service, and it compared the outcomes for users versus non-users. Interestingly, only a minority of people who were allocated to the rapid response service ever actually used it, so it wasn't a complete take-up of it. The outcomes were preferred and actual place of death, use of community services, out-of-hours contacts, etc. Now, and carers' quality of life using the SF12 and EQ5D. I've just picked out for this some key outcomes. So the relative effect for selected outcomes, the place of death, the relative risk of dying in your preferred place of death was just marginally higher than if you didn't get the service. 1.01 to 1. Hardly less than 10% change there. On the other hand, the use of community services was somewhat higher, the relative risk 1.19 for social services, and nearly 10% higher for if you were referred to a Marie Curie nurse. So there were some positive outcomes there. The next UK study was much larger, nearly 3,000 patients. This was based on the Marie Curie Cancer Care Delivering Choice program, and that covered, it was a very complex program covering out-of-hours service, a telephone helpline, hospital-based nurses, an end-of-life coordinator, and an electronic register. Normally we're talking about complex healthcare needs. This is a complex service delivery model. And there are lots of different outcomes, place of death, acute hospital, home, etc. And then number of hospital visits, emergency admissions, visits to accident and emergency. Again, I've just pulled out a few key findings. The preferred, as opposed to the actual pace of death, if you got the service, then, you died, if you were, put it the other way around. Hospital was actually much less likely to be a place of death in this particular service, 0.32. Home was somewhat higher, nearly 40% higher chance of dying at home with this particular complex service. The number of hospital visits in the last 30 days, admissions were reduced, 0.85 there, and accident emergency visits were also much reduced. So it had clearly a visible, measurable impact there. This is the Italian study, smallish 400 patients, and it compared a palliative home care service, defined by the Italian system, versus usual care, but they didn't actually describe the usual care very well. And again, these are the outcomes, place of death, length of stay, and number of hospitalizations. Looking at some of the selected outcomes, the place of death was much reduced for hospital. The relative risk was 0.31, and was much increased for people dying at home. So could be a significant impact. The trouble is that this was not a randomized study, and we can't really be sure of that. The length of stay in hospital in the last 2 months, if you had what they called usual care, it was 19.6 days. If you had palliative care, palliative home care, it was only 4.2. So a significant reduction in people spending time in hospital. And finally, the Canadian study, large study, 3,000 patients, and they looked at specialist palliative care, again, versus usual care. And one of the problems with all these studies is they didn't really describe what usual care was, because it's a bit of a mishmash. Their outcomes were hospitalization, number of people in hospital in the last 2 weeks of life, number of visits to A&E, and the place of death. Pulling out some selected outcomes. If you want to look, there's a very large document of the whole evidence that I'm quoting from here on a nice website. The place of death was reduced in hospital. Relative risk was 0.57. You were really reducing your risk. And translating that into numbers, if you had usual care, 285 people out of 1,000 would die in hospital. If you had the specialist palliative care service, that was reduced to 162 out of 1,000. Hospitalization in the last 2 weeks of life, the relative risk was reduced, 0.8. Again, putting into numbers, usual care, 392 would have hospitalization in the last 2 weeks of life. If you had the specialist palliative care, somewhat reduced, 316. Now, I said we didn't have any economic data, but what we did, we looked at typical UK resource costs and the elements of what the committee felt were important aspects of out-of-hours care, and we then looked at what that would cost for a typical CCG of, I think, 265,000 people, and based on 0.8% of that population. That's a number which we feel needs palliative care in the last year of life. And I won't go into detail with the figures, but we came up with some figures for the total cost, for instance, of a coordination service, 640,000, an out-of-hours advice line, 183,000, hospital home service, very expensive, 873,000. What level of outcomes would make these cost neutral? Because obviously there's no new money for that. What we're trying to do is what can we do to actually save money somewhere else to implement some of these things. So we were able to calculate, the economists were able to calculate that, for instance, if you reduce deaths in hospital by 63%, that would pay for the end-of-life care coordination system. If you reduced inpatient days for emergency visits, that would reduce by 8%, that would pay for the hospital at home service. So you can do these calculations. It'll be interesting to know what you think about these, but these are conjectural, these are hypothetical savings that you could make. So what is the impact of NICE guidelines on research? And I'm looking at all the last 10 years or so. All the guidelines that we produce have research recommendations, and they have an impact on open funding calls from NIHR and other bodies as well, charities like Marie Curie. The NG31, Care of Dying Adults in the Last Days of Life, did stimulate a new way of end-of-life care research. But more recently, the James Lind Alliance has been helping us with the priority setting partnerships. So Marie Curie entered in with the James Lind Alliance for the end-of-life care priority setting partnership, and the National Cancer Research Institute has recently done one for people living with and beyond cancer. And just to finish up with, these are the top 10 priorities, out of the top 10 priorities, these are 3 which actually cover out-of-hours care. So number 1 was, what are the best ways of providing palliative care outside of working hours? So that came out top from professionals and particularly from patients and carers as well. Number 8 out of the top 10, what are the benefits and the best ways of providing care in the patient's home? Does good coordination of services affect this? And number 9 was, what are the best ways to ensure that there is continuity for patients at the end of life? And clearly, out-of-hours care has a very important part to play in that. So we're working to these research agendas, and one of the things that we've recently set up in the UK is a consortium called the NIHR, National Institute of Health Research, and Charities Consortium for Hospice and Community-Based Research. And if you want to know more about that, I can tell you more about afterwards. But that's taking forward this agenda to say, how can we step up the quality, the amount, and the quality of research in these areas? Out-of-hours care is one, but we're looking at the whole spectrum. Thank you very much.